Welcome, everyone. Thank you so much for joining us. We're going to hold on just a minute here while our platform's letting everyone in. But in the meantime, feel free to head to the chat, give us a greeting, let us know where you're tuning in from today. We would love to hear from you. Welcome, welcome. Thank you so much for joining us. We'll be started in just a minute here. Perfect. I love to see our numbers growing. Feel free to head into the chat. Give us a greeting. Let us know where you're tuning in from today. We love to see who's joining us. And oh, good. I see those coming in. Perfect. Well, hi, everyone. Thank you so much for being here and welcome to today's webinar, Conquering Recovery is Telehealth Right for Me? My name is Jackie Zimmerman. I'm the Public Education Associate at Mental Health America's National Office, and I'll be moderating today's webinar. I have a few notes before I introduce our speakers for today. This webinar is being recorded and will be emailed out to all registrants within 1 week. We currently do not offer CEUs, but if you would like a certificate of attendance, we do have a link for you to request one. I'll post the link to that shortly in the chat here, and it will also be included in the follow-up email. We might have some time at the end for some Q&A with the audience, depending on our time here today. So please feel free to post your questions in the chat, and we also welcome all comments in there, and any knowledge that you all would like to share in the chat is welcome as well. So feel free to utilize that feature. And now I'm happy to introduce our speakers for today. We have a wonderful panel with 4 individuals joining us with different backgrounds. So really looking forward to this discussion with them. First, we have Josie Cooper, who is the Executive Director of the Alliance for Patient Access. At AFPA, Ms. Cooper has worked in stakeholder and clinician mobilization, developing policy and educational strategies to improve patient access to care. Welcome, Josie. We also today have Dr. Robert Caudill with us, Professor of Psychiatry at the University of Louisville. He is the Residency Training Director with an interest in optimizing the role of technology in postgraduate medical education. He's also the Director of Telemedicine and Information Technology Programs for the Department of Psychiatry. Dr. Caudill is a past chair for the Telemental Health Special Interest Group of the American Telemedicine Association and fellow in that organization. He is co-chair of the Telehealth Task Group of the National Network of Depression Centers and is a distinguished fellow of the American Psychiatric Association and a founding member of its Committee on Telepsychiatry. Welcome, Dr. Caudill. We also today with us have Dr. Andrew Rosenzweig. I'm trying to get this right for you. Our chief, Dr. Rosenzweig is the Chief Medical Officer at Forefront TeleCare, a national leader in telehealth linking behavioral specialists to rural, underserved skilled nursing facilities and psychiatric hospital inpatient units coast to coast. He's thrilled to be in a position to use both his public health training and his geriatric psychiatry training to help attain that goal. Welcome. And today with us, we also have Salma Abdou, who is a psychotherapist and marriage and family therapist currently working at Brightline. Salma works with various populations, age groups, and people of different backgrounds and beliefs. Her professional approach is drawn from various integrative therapeutic techniques. She's utilized knowledge and creativity to make therapy sessions more flexible and pleasurable for all of her clients. Welcome, Salma. We are so grateful to have all of you with us today. As you can tell, a great panel with various backgrounds. So we will jump right into discussion. And like I said, everyone watching, please feel free to post questions in the chat. I'll be collecting those as we go. And if we have some time at the end, we'll go through some of those. But welcome, panelists. We will start it right off with a more broad question for you all. In terms of the increased mental health crisis we've seen in the past few years, how has telehealth impacted mental health care as a whole?
I'm happy to jump in and start. I think telehealth has made a huge impact on mental health, but really on the entire healthcare system, right? This is a technology that's been available for a long time, but it really wasn't until the sort of onset of the COVID-19 pandemic that the restrictions that kind of limited access were taken away through CMS, allowed for greater access. So I think it's made a big difference for patients maybe who might not feel comfortable seeking care in person, who may not have access to ongoing in-person care, and also may have a role in supporting providers at a time where we know that there's a significant mental health care provider shortage. So I'd start there and just note that it's definitely not a one-size-fits-all approach. I think it has its place, but like any technology, it's kind of a tool, not a solution to everything. But I think it's certainly made a big difference for a lot of patients.
I can also piggyback off of what Josie said. I definitely agree with telehealth. I think it positively impacted the mental health industry as a whole. I feel like it allowed more patients to have access to therapy, whether it's, their schedule, whether, going to the office conflicts with their time, even like financially. I think one of the major things that a lot of my clients told me was it was cheaper for them to, have a session remote rather than them coming into my office, because, everything is just more expensive now, and it's just, it's easily accessible for them. And I think it also leaves room for more improvement in the mental health industry. And, it's definitely a great, thing that, we have access to, I guess.
I think it was woefully underutilized for years. I mean, it was ready to play a major role in the healthcare environment, but lots of mostly administrative and bureaucratic and legislative blockages prevented it. So now that we have it, it's here to stay. The other thing is, before any of this happened, we had hypothesized there was a bit of a hidden group of patients that we never really saw because they were avoidant or couldn't overcome the various logistical barriers to come to care. And being able to see those patients in their home for the first visit creates access where none previously existed. So obviously the change is profound, but it was overdue also.
And I would just add, I'm first of all thrilled to be part of this distinguished panel. I know Dr. Caudill probably doesn't know this, but he's taught me a lot about what I know about doing telepsychiatry through his work. I would just add to the previous comments that I think it's helped decrease the stigma associated with mental health, and it's also helped incorporate psychiatry into general medicine in more ways than I envisioned it would. For example, by having mental health services via telehealth in hospitals and nursing homes a lot more than in the past. I think it's opened up a lot of healthcare professionals to what we have to offer in this field. So I think that's been a nice positive outcome of this as well.
Absolutely. Thank you all for those comments. And in there, I heard lots of things. And one thing that is often talked about with telehealth is access and that increase of access. And I've even seen some of your comments already in the chat about how it has impacted your ability to receive care due to barriers like access, whether that be financial or physical. So in addition to access, and we can talk about that too, but what other benefits have you seen telehealth for mental health care specifically provide?
I had one other thought I wanted to toss in on the word access. We use access and we think of that as a uniformly good thing because it mostly is, from our end as providers. The other side of the equation looks at access as utilization. And that's a dirty word to them. They don't like utilization above a certain minimal standard that they establish. So that's been the push and pull, and that's where we're really going to have some advocacy efforts ahead of us to maintain the level of access we've achieved with this.
I also want to answer Jackie's question regarding telehealth. I feel like telehealth is also like breaking the stigma, but it's also allowing people to be more comfortable with therapy. One thing that I think comes attached with therapy is no one wants to be seen walking into a therapy office. At least with the population that I work with a lot of Muslim Americans. And, mental health is very stigmatized amongst the population that I work with. And, oftentimes my clients will say, like, nobody saw me come in here, right? Like, no one knows I'm here. And, you have to reassure them, like, this is a safe space. Nobody knows that you're here, and like explain to them a lot of the confidentiality that comes forth with, coming to therapy. But I think with telehealth, it gave clients this sense of privacy and this sense of liberation where therapy is not as bad as, the media or, the world had made it out to be. And I think that's awesome to allow, populations, across the world to just, utilize this telehealth and say, okay, it's not as bad as I thought it was. And that way they can get the help that they need in their comfortable setting. Not a lot of clients enjoy being in therapy office versus doing a therapy session from their home or their comfortable space or their safe space. I think that definitely plays a huge role in their treatment plan as well.
I'll just add, and would be curious the providers' thoughts on this, but I represent an organization that works with healthcare providers on policies. And one thing that we heard frequently from that group around, broader than mental health, but also specific to mental health, is that it was helpful to be able to see into a person's home to really get a sense of the fuller picture, that could help them provide the best possible care. So I've always thought that was an interesting point, but if the clinicians on the line have thoughts, would be curious.
There have been some lively discussions about that, actually, and in terms of doing a mental status exam. Historically, the patient would be in a setting of our choosing, so we couldn't read anything into that. But now the patient, to some degree, has relatively unlimited options as to where they're being seen. We skipped right over the education step we had hoped to bring about before telehealth was rolled out nationally. We just kind of had to do it and hit the ground running because of the way the pandemic structured things. But now, there's a question about whether it should be an element in our mental status exam, examining the background and why the patient chose to be seen here and not there, the things in their wall. I mean, there's a lot of anecdotal stuff about patients that were difficult to reach until some trivial element of their home decorating was noted. There's a gentleman I know who was working with a patient who was pretty shut down. He noticed some Chicago Cubs memorabilia in the background, and they got talking about that, and then everything followed from that. But that was the key to getting, which never would have occurred had they met in a traditional office.
Yeah, I totally agree. I would just add, to that point, it's also, I think, enabled more creativity in how services are delivered. For example, I was trained from the very beginning of my career that in many patients, a combination of medication management and psychotherapy does better than either alone for many patients, right? And so by utilizing telepsychiatry, it's so much easier to connect patients with a provider for medications and a provider for therapy, because now they don't have to drive to two separate offices. It's much less complex from multiple perspectives. So that's one, I think, additional benefit. And I think just what I've seen is the resilience of patients in their accepting this technology to see their providers. I treat a lot of older adults with even advanced dementia, various degrees of cognitive impairment, various degrees of paranoia and severe psychiatric symptoms. And it's been clear to me from the outset that it's a rare patient who resists the technology to make a connection with me as a provider. So I think the benefits are only beginning to really be appreciated.
Patients were way ahead of clinicians on this one. They were asking for it, they were requesting it. Now that they have it, I don't think they're going to give it up easily. but selling it to my colleagues was always the challenge, and they had lots of questions about it. And one of the questions was, well, is it as good? And I was trying to, well, what does that mean? That's not really the right question. Is it the same? No, obviously it's not the same. But the fact that it's not the same doesn't mean it's automatically worse. So there's appropriate cases that are more appropriate than others, I guess. And what I would say, the question I asked about what benefits are coming, there's a population of patients that the safety issue of being able to be seen from their home is paramount. And the whole idea of coming in and being seen by anybody out in a closed room where the doors, may be locked behind them as far as they know, those folks were hard to reach in our traditional clinical settings. And we're starting to see them in a virtual realm, and it's been remarkable.
Absolutely. That's a great point with the safety and comfortability that Salma had touched on in the beginning as well. And I think with mental health care, it's so unique to the patient that providing as many spaces that feel safe to the individual for them to join is so important. And telehealth really opens that up and just gives the patient so much more control over, like you said, they can join from virtually anywhere, any environment that makes them feel comfortable and safe, versus that fear, uncomfortability, or limited access to going to a physical office. And like you said, Dr. Rosenzweig, is also then maybe they have to go to multiple offices. And for some people, that is just extremely challenging. And so there are so many wonderful benefits. And I think, like you all have stated, it's kind of just the beginning for learning this new world of telehealth with therapy. While there are so many of those benefits, I'd be curious to hear from you all what the greatest challenges you've seen come up with this for both patients and providers, and maybe how can we address those challenges and work through them?
I can start. I think there's a couple issues. One is understanding how to navigate it to a point that's already sort of been made. This came on very, very quickly. And so there were a lot of patient groups were kind of catching up on, all right, what does a patient need? What materials do they need to help understand how this visit's going to go? Is it helpful to do kind of a pre-call to make sure the tech is working beforehand? Does anyone actually have time to do that? I think that the understanding from the patient side of how to do it successfully and what it would take to have a successful visit can be a challenge. The one that I think is certainly being addressed. Another more systemic issue, I think, is broadband access. There's still a huge number of places in the US that lack that. And so access is not always equitable. And so I think, those are the two challenges that we've seen.
I think the unwanted role that fell on many of my colleagues was that of tech support for their patients. So they had their schedule, they had their patients, but they were marginal to begin with in their own ability to access technology oftentimes. And then suddenly they went from a 100% in person to a 100% virtual, and they didn't like technology any better after that was all said and done. So that was certainly one of the challenges that we saw early on. The other one I think too was when pitching this to my colleagues, it's interesting to see people when they're under duress fall back on sort of more primitive defense mechanisms like all or nothing thinking. So I was trying to convince my colleagues, and sometimes in other specialties, that much of their work could be done over video, and some of the things that they were bringing patients in to their offices in person could be done over video. And in their mind, somehow I was telling them, well, you have to give up your office and you have to do everything virtually, because once telehealth is here, we won't use these offices. And I said, who's saying that? That's not part of it at all. This is just an additional tool. It's a resource. Use it where it fits, but not elsewhere.
I'd like to comment just briefly on some of the provider challenges related to the regulatory and kind of state by state requirements that differ, licensing burdens sometimes that providers have to be licensed in the state where the patient's residing, issues regarding, say, controlled substance prescribing via telehealth can be something challenging to wade through, right? Assessing the ongoing kind of legislation that's pending regarding telehealth rules, as well as, I think many of us are fearful of the lifting of the waivers and the changes that have been made since COVID. For example, once the COVID emergency is lifted, what does that mean for those of us providing telehealth services? So there's a lot to wade through in that realm. But I clearly think that the benefits outweigh those challenges in the end. But I think providers sometimes naively come to it with, the notion that they can, just sort of do what they were doing without doing that extra homework. Like, for example, I know, just by being able to provide services now in patients' homes, which is relatively new for many of us, the issue of patient safety that Dr. Caudill spoke so smartly to also has the other side, which is, we as providers in other states where the patient may be, have to think through how to intervene, say if there's an emergency, right? If we need to contact local, law enforcement because of a potentially dangerous situation, we have to have done work ahead of time to, figure out how that might work, right? What are the local resources in that community? How do we reach them, et cetera? So there's potentially more to it than some people may realize.
I think one of the things that we mentioned is one of the questions in the chat is about seeing patients in crisis. And a crisis plan should really be in place from the first session. That should kind of be spelled out. We all know that 911 is a useful number, but it's a local number. And so if you're not in the same area of the patient, you need a better plan than that. And there's ATA and APA guidelines that are available for practitioners on our professional sites that are well referenced and have good evidence base.
Any last thoughts on that one before we move on?
I would follow up on Dr. Rosenzweig's comments about the regulatory environment and the barriers to this. The current public health emergency declaration ends January 11. All indications are that they will renew it an additional 90 days, but these are 90-day periods that have to be renewed. Most of us thought it would expire in January, quite frankly. And I think the current, when you look around, does it feel like we're in a public health emergency right now? I don't think the consensus would say that we are, but I figured the midterms explained this most recent one. Picking it up and doing it again in January, though, it looks like it's going to get renewed for at least an additional 90 days coming out of January, because they have given some assurances that it would be more advanced warning than this if they intend to not renew it.
Thank you, Dr. Caudill. My next question for you all is on these challenges we've already talked about, and something that we've seen on our side at MHA come up, especially with medication side effects and diagnosing conditions like tardive dyskinesia. How are providers overcoming challenges like this, and what do patients need to be aware of regarding diagnosis through telehealth?
Start since nobody's already jumped in, but so we work at the Alliance for Patient Access with the Movement Disorders Policy Coalition. It's a coalition that we work with MHA on and manage, and this is something that we hear come up a lot. That there are challenges diagnosing some of the movement disorders, including tardive dyskinesia, and so I think it's important for providers and patients to be aware that, to know that going in, and know that it's at some point in person, at some interval may be perfectly appropriate, may be helpful in diagnosing these. I know that they can be diagnosed via telehealth, but we would just encourage folks to take a balanced approach and just make sure you're watching for that.
Yes, I completely agree. I think, movement disorders, tardive dyskinesia, I think really are issues that point to, the lack of perfection, if you will, of a purely telehealth delivery modality. So to Josie's point, I think, combining an in-person visit with perhaps the remainder of the visits being through telehealth is perfectly sound. For example, the Ames test, I think, can be administered pretty accurately remotely, but perhaps for that initial diagnostic clarity, it would be better, to have a thorough in-person assessment. Certainly aspects of the neurologic exam, are not quite as accurate in a remote setting. Interestingly, my wife's a neurologist, and I asked her about this last night in preparation for today's webinar, and much to my surprise, she does neurologic exams, very, very often and very, very detailed. But in her mind, most of her exam really can be done quite well remotely, but not everything. I mean, obviously checking reflexes, examining for cogwheel rigidity, perhaps assessing for antipsychotic medication, adverse events in the motor area could be challenging, but having patients walk, having patients do finger to thumb tapping exercises are all quite realistic and doable remotely via video conferencing. And I just as an aside, I was curious to the panelists' feeling about telephone only psychiatry. I know I've struggled with that, given the importance of the visual connection to the patient to assess their affect and their reactions to comments. And our whole training involved doing a thorough interview with a person, but I'm slowly coming around to how to incorporate telephone only visits, given a lot of what we've talked about, the lack of device access, affordability, broadband limitations, etc.
Well, you beat me to it on the comment on the telephone. And I was going to say that, we came at it from a different angle initially when I was looking at what could be done with video. The idea was that the goal point was to beat treatment as usual. And if treatment as usual is nothing, which it oftentimes was in some of these geographically isolated areas, then beating that was a low bar, but we were able to reach it. I'm a big fan of not making the perfect the enemy of the good. And we tend to hold the in-person encounter up as the gold standard, and perhaps that's a good reason. But as a program director, just because you've seen a clinician doesn't mean you've really been seen by a clinician, because I'm at a teaching hospital. We catch a lot of things that are obviously there but weren't caught earlier. And it's not necessarily, I mean, not everybody catches everything. I'm sure I miss something too once in a while. But if you're looking for tardive dyskinesia, you'll tend to find it. If you don't tend to look for it, you might miss it in person too. So the in-person versus the video is no guarantee that things don't get missed. And the key thing is getting people into the system oftentimes. So, I mean, if I've got a patient that's been on an extended exposure to a older generation antipsychotic, tardive dyskinesia is in my thought process from the start. And if there's any subtle indications of it, and on the video, then I can have them easily come in for a more detailed and elaborate examination. There is a body of literature referring to the Ames exam having been administered over video, and it does tend to hold up. I mean, so basically it gets you in the ballpark pretty quick.
We'll go to our next question then. For a patient that might be seeking mental health care for the first time, what advice would you provide them about if telehealth is a good fit for them? And, what specific needs, when you're thinking about patients, should they be considering in those decisions?
Well, historically, the in-person visit always came first. I mean, that's been around forever, right? So the model that was hypothesized by Peter Yellees and his group out at UC Davis in 2012 talked about a hybrid model. And pre-COVID, we were looking at all these different opportunities to get psychiatrists in particular to utilize telehealth technologies in a bigger way and how they could bring that into their existing practices. Because again, the pushback has mostly been on the side of clinicians. Patients seem to be much more ready to accept this. And so the hybrid model came up, and everyone thought this would be the next big thing. And that was that you would use your existing brick and mortar in-person practice. And at the end of an evaluation, for instance, you could discuss with the patient the option of being seen over video on the return visit. And then you just simply pivot your chair away from the now empty chair over to your monitor, and you meet that patient on video the next time. I don't think over the time that's going to prove to have been what we're going to wind up with. I do think we're going to wind up with in-person brick and mortar being reserved for in-person visits. And I think people are going to see their video visits probably from their home. It doesn't make a lot of sense to pay commercial real estate values for a brick and mortar presence if you're going to could be working from home just as easily. So in terms of advising patients, similar kinds of things. I mean, there are a subgroup of patients who want to be seen for whatever reason, in person preferentially, and if we can accommodate them, we should. But that's not the majority in my mind. Of the patients that we've converted to video out of necessity have almost uniformly stuck with video. And so once they get over that initial technology hurdle, then they're pretty good. The caveat I would say coming back, however, is we've set such a low bar for technology. So I've got people talking to me on iPhones with not great bandwidth, walking through their homes, bobbling along, and I'm meeting patients with, a cigarette in one hand and a beer in the other, which is a rather new clinical encounter for me. So we didn't socialize people to this as thoroughly as we would have wanted to. So I think we've got to back up and do some of that and talk about what are the boundaries around a clinical encounter and what should that all look like. That's work, still lies ahead to a degree, but it's more tweaking and adjustment now. At least we've gotten over the big initial hurdle.
I would just say from the patient side, do your homework. If you haven't tried it and you're thinking about it, there are a lot of really great resources out there, including from MHA. And so know what you're walking into, know what to expect. Take a look at those resources and know how to advocate for yourself. I think that's important in everything, but I think it's important in video too. Know what questions you want to ask. Don't be afraid to ask them, and then the only other thing I would add is, and this gets to the point that was just made, our chairman always talks about sort of you revert to in person if one person's not comfortable with it. So if he feels comfortable administering care via telehealth, but the patient's not sure, you revert to in person. If the patient's comfortable, provider's not sure, you revert to in person. And then if both are comfortable, then let's go telehealth. And so that's what we always think about from our side as an organization.
I also believe that it just depends on the client that you're working with, and it's the clinician's responsibility to use their clinical judgment. I know for me, I have some clients that I would much rather see in person only because it would benefit them more than seeing them via telehealth. Not everyone is comfortable with telehealth. as good as it is and as great as it can be, not everyone is comfortable with it. Not everyone sees that it fits their treatment plan in the best way possible. I know for me with certain patients who are experience intense trauma or need more hands-on work, I would definitely see them in person rather than telehealth. I think it just creates that therapeutic alignment in a session when you are one-on-one with the client and you're able to, I guess, resonate with what they're saying in a room rather than it being over a screen.
I guess there's a continuum of that, though. I would say that I've seen a lot of trauma patients in various forms as well. And most of them in mine, again, don't want to come in and have to be dealing with all the various logistical hurdles to get down to my in-person office. Now, I'm in an urban setting, and there are lots of other challenges that may be perceived as threats and dangers too, unrelated to the practice. But to be seen in their home seems to give them a sense of security oftentimes too. Another thought, you mentioned a first-time patient. I would say be prepared to identify yourself. And we did not properly socialize either side before we just hit the ground running with all this. But the idea is there were some basic sort of social etiquette rules of telehealth that were there from video teleconferencing in business world that a lot of people just didn't know. If you should identify everyone in the room at both ends. That's a routine thing. So if you're going to be there with your spouse or your partner or your parent or somebody else listening in, be prepared to tell the clinician that that's who's in the room, because they're not always on the camera shot, but they're every part of the session in every other way. Same thing applies to the clinician. I have trainees with me routinely. Sometimes they're actually beaming in from a separate location. So there's three Zoom people in the same room. In that case, it's a little harder to hide. So that's the advantage. But then I need to explain to the patient why they're there. And then, I routinely ask a couple of identifying questions, minimum date of birth, just to make sure for the first time I'm meeting a patient, I don't know who they are for real. I've never met them before. And I need them to identify with some sort of independent metric that tells me that this is indeed who I'm scheduled to see this hour.
Yes, absolutely. Terrific points. I've found that issue on both the provider side and the patient side in terms of the etiquette and being sure to maintain privacy in a session, particularly challenging, say in a skilled nursing facility, right, where there's a lot of activity and not a lot of privacy, room to room and so on. But I think for the first-time patient, advising them, as we said in advance, that they really should sort of imagine, that the hope is that it's going to simulate an in-person visit, right? So that they need to prepare themselves for what a session would be in person, and to try to do it in a private setting where there's lack of distraction, lack of access to the beer and cigarette kind of thing. But it's really worth repeating and being very transparent on the provider side about acknowledging that for example there's security, HIPAA compliance, that there's nobody else listening in, and so on. So there are, I think, a lot of those sort of housekeeping items that are important to discuss back and forth.
If the clinical practice takes care of these things, and it doesn't necessarily automatically fall to the clinician, but they properly advise and educate patients before that first meeting, it will also go much better. So sort of giving them some heads up about what settings are appropriate and inappropriate. I can't tell you how many sessions I've called in on and somebody's driving a car down the road. And I have to remind them that that's not where we're going to conduct the session. So please pull over and we'll resume. The other thing that might be an issue is state. I'm on a border state. I mean, I can see the Indiana from my office in Kentucky. And I'll get in there and the patient is they work in Louisville, but they live in Indiana and they want to be seen in their home in Indiana. Well, I'm not licensed in Indiana currently. I will be probably in the next few months because the current practice is working that way. I'd previously seen mostly rural Kentucky though, so now I'm going the other direction, but now I need a license in Indiana. And so technically I have to tell that person, if we're going to prescribe, you've got to drive across the bridge because that's where I practice. So these little silly things, but they may seem silly, but they're still in the regulatory language until we get that changed. We have to live with what we've got. So educating the patient to remind them that, you know, your clinician today is licensed in Kentucky. He'll need to see you there somehow.
Absolutely. Thank you for that. I think a big theme is preparation and education. And someone in the chat had a great question along those lines that I'll post to you all. This viewer said, thank you for acknowledging the broadband challenge for many, particularly in more rural, remote areas where telehealth could be most beneficial. These areas are also where there can be significant pushback by clients due to not being familiar with either technology or telehealth. What techniques, outreach, or encouragement have you found to be the most successful in introducing telehealth, explaining it, and assuring that there is actual hands-on capability on the client's part to utilize telehealth?
I would say there's preparation that goes into all these things. So you kind of ought to know what you have to work with to begin with. None of us really expected audio only to be a thing. I didn't think that was going to happen ever. I mean, I thought, you know, organized medicine had missed the ball 100 years ago when we gave that one away and just said, well, we won't be reimbursed for anything we do over a telephone, which meant that we did very little over the telephone. So when we were pushing for video because we thought we had a strong case there, and then nobody asked for audio, and we got that too during the pandemic. So we didn't know what to do with it, but it was very helpful because there were lots of these geographical areas, as you know, that once you got outside of the county seat where they did have decent broadband and into that last mile kind of thing, the speeds fell off greatly. You know, if you don't have a lot of technical proficiency, you probably don't know how to run a speed test. But ideally, I mean, our front office is before we do the visits, you say, go on Google and type in the word speed test and hit enter and give us the numbers that come up. And below a certain amount, Zoom tells you Zoom doesn't really work at that point. You have to turn off the video if you want to get intelligible audio even. So that was part of it. Have you comments there, I guess.
Thank you, Dr. Caudill. I will wrap up with one question that I had for you all and then go to a few more chat questions as we have time. But on a different note, let's turn to the data. And now that telehealth is being more heavily utilized, what does the data tell us about how telehealth is working?
I think there's been a lot that's come out more recently about telehealth. You know, there's obviously been a lot that's being researched, given that there's been this huge uptake. And what we see is that there's some positive, some not quite as positive. I've seen studies that say it, you know, can really help with disparities. Others that particularly given the rural divide, maybe it doesn't help so much because there's so many limitations that patients might have in terms of technology access. And so I think it's, you know, again, I think it's a tool, right? It's not perfect for everybody. It's great for a lot of people. It's done a lot to expand access. And so I think there's a lot that we can keep doing with the data. And we have been, as an organization, encouraging CMS and others with the power to do so to really keep putting dollars behind doing more research to make sure that we're identifying who this is best for. If there are certain populations where it might not be, you know, maybe the best option. So the more data, I think, the better.
I think we're inevitably going to have a lot more data to analyze as a result of the reaction to the pandemic. But I can say this from what I've seen to date is that there was a fair amount of research done prior to that. And it did indicate more or less many of the things we've already covered, and that is that it's not the same as in person, that in some instances it's maybe a little worse, but in some instances it's better. And that was the surprising finding to many people, that they weren't willing to kind of look at that side of the equation. So by and large, the research is kind of showing us what we would have expected to see here. It's not a cure-all. It's not meant to replace the in-person visit. It's an adjunct to what you were previously doing. I was, when the pandemic rolled out, my role at the university was actually, I kind of left my role in psychiatry because our department just needed to scale up what we were already doing. Several of us were doing a lot of telemedicine. And so we just did that across the board. But the rest of the School of Medicine had very little experience with this. So I did a lot of work actually with non-psychiatric departments who, like I say, had never given a moment's thought to what they would do if they couldn't see people in person. I just said, I get it, 100% of your practice can't be converted to virtual visits. Could 10%, could 20%, because that's what you're going to get to do tomorrow. Would you like to do that part? And that was pretty compelling. So people did jump on it. One of my most rewarding experiences was working with orthopedic surgery. And you would think, well, what can you do as an orthopedic surgeon over video? It turns out a whole lot in terms of post-operative wound inspection and all that stuff. Patients can manipulate their own limbs just like you would in the office. And so banged up orthopedic surgery recovering patients didn't have to drive in a car 3 hours each way to come see it, somebody for 6 minutes to look at their wound. Those kind of things they're going to continue to do beyond the pandemic. I did have one other thought too, that last question about access into rural areas and bandwidth. One thing to look for there is what the VA has done. The VA has been very successful in this regard because they sort of have a commitment to meeting their patients wherever they are. And for various, sometimes sad reasons, a lot of veterans who are pretty traumatized wind up in geographically isolated areas. Go figure. So what they've worked out is a system where they actually do issue the equipment to the patient. They sign it out somehow and they work it out. I mean, their funding stream and mechanisms are very different than ours, right? But they can actually give somebody a laptop with a satellite connection if they have to, if that's the means of getting them into care, as opposed to having them drive a long way out in rural roads where they're not likely to do that anyway. So there are solutions out there. There may be an Uber Eats kind of deliveries mechanism worked out some point that drops off iPads and picks them up at the end of the day. I mean, somebody can go market that. I don't have time for it, but I think there's money to be made there.
Absolutely. And just back to the research question briefly, as I read the literature, it seems that even looking on a disease specific basis, whether you're looking at depressive disorders or cognitive disorders, psychotic illnesses, it seems that the few but some, I think, quite well done studies that have been done in those separate areas show pretty good outcomes in terms of not only measures of symptom improvement, but also improved patient and caregiver satisfaction, and so I think combining the experience, we know that adherence and compliance with mental health care in general is poor. I think telehealth is a very real way to improve those aspects of the patient experience, never mind just the outcomes of the illness themselves, outcome measures.
To date, with adequate sample sizes, I'm not aware of any study that's shown inferiority. So, I mean, that's the key thing. It gets back to some patients are going to do better and some patients are going to do worse, and most are going to do about the same.
Thank you all. Appreciate your thoughts, knowledge, and feedback on those. I'm going to go to a few questions in the chat, and please feel free to continue adding those questions in, everyone. I have one question submitted specifically for Salma. This viewer said, you briefly mentioned working with Muslim Americans. Have you seen telehealth play a role in addressing some of the healthcare disparities that we see across the healthcare system?
I believe that the telehealth services provided easier access to every population, not just the Muslim Americans. But if, to answer, the specific individual's question, I do believe that, working with Muslim Americans, just about mental health as a whole, it requires a lot of psychoeducation, again, because of the stigma and the taboo and, the cultural differences. So I feel like once you're able to, once the client, I guess, is able to grasp a really good understanding and, the proper psychoeducation of what therapy is as a whole, it just makes the process at least 30 to 40% easier for them to onboard treatment and, for them to, go in with a much more open mind. I believe that, with telehealth, it allowed me to open my eyes to a lot of disparities that we do see in the healthcare system, because not every individual, I believe, is provided with the proper resources. I feel like a lot of, the clientele that I have worked with, mental health is a whole new territory for them. I've had clients coming in and saying, I'm dying. And then I'm like, okay, let's take a deep breath. Like, let's, talk about the symptoms, and they're having a panic attack. So I think with the Muslim community, a lot of them don't even have access to telehealth. Yes, they have the iPhones, they have the laptops, they have the computers, but a lot of them don't really know how to utilize the resources that they have for the telehealth services, which is why, in my office, a lot of my clients do prefer in-person sessions. Again, the telehealth does work for the clients that are able to have the proper access to them. It's sad that a lot of clients, it's for us, it's just a push of a button, just click on the link and, you'll be addressed to the session. But, for a lot of clients, they're like, what link, what's a link? So it just requires a lot of patience and a lot of psychoeducation and just, a lot of understanding and putting yourself in their shoes. Like, okay, they don't understand what this means. How can I meet the client halfway? Because ultimately that's really is what it's all about. Meeting the client halfway, making sure that they are receiving, the best treatment services for their particular diagnosis.
Absolutely. Thank you so much for that insight. We really appreciate it. I will round us off with one last question that we have here from someone else in the chat that said, one drawback I see with telehealth dealing with mental health is body language can be very important in diagnosing someone. That should be observed in a multi-dimensional fashion. What drawbacks do you see in observing a single dimension video environment?
I guess patients will do mostly what we ask of them. So some of this, if we don't feel like we're seeing them properly, we can ask them to stand up or move closer or further from the camera. We do a lot of training on the clinician end on something called parallax, which is gaze angle and all of that stuff, which used to be a big deal, but since everybody got thrown into the pond together without any warning, assessing things like eye contact is very tricky, because they may be looking at the image of your eyes on their monitor very clearly, but they don't appear to be looking you in the eye. And that's because they haven't been trained like a TV newscaster would be. So YouTubers actually have figured this out pretty well. There's a lot of good clips on how to be a good YouTuber and how to put those out. And they talk about, talk to the camera, which is exactly what you need to be doing if you want to appear to be talking to the patient. So most of our clinicians, skip that class in medical school or wherever. They never got it. So there's that on the presentation end. But then, of course, if we didn't get it, our patients didn't either. So we may think they're not really looking at us and then realize that, well, they're doing something different. People that are using the telephone for their audio, but their audio piece, but they've got a PC where they're doing their video, will look a little disconnected. It's not perfect. It's not the same. I would guess if you feel like you're still unable to get the diagnosis refined to your satisfaction, we still have the option of an in-person visit. So that's the good news. We're not trying to eliminate that. We're just trying to augment what we've previously done.
Absolutely. Any other thoughts on that one? Wonderful. Well, thank you, Dr. Caudill. I know that it is new for many, and something that is a great tool that we can start to integrate and think about in mental health. And I know on Mental Health America's side, you know, with the increased access and so many benefits coming out of it, like Josie had said, there are resources available for you to learn more and to really figure out, is this the right fit for me? And preparing yourself so you know what to expect and can feel more comfortable in those situations where it might be a new experience for you. Before we wrap up and I give a few closing remarks, any last thoughts or tidbits of knowledge that our panelists would like to share today? Please feel free to, if there's something you haven't had the chance to say yet that you want to leave our viewers with.
I'd like to put in a quick plug for any of the clinicians who might be on the call to take advantage of resources like the American Telemedicine Association, the American Psychiatric Association, and their telepsychiatry toolkit. They have the best practice guidelines out there for telemental health, and these two organizations came together. They're being revised as I speak, but it is the sort of the state of the art, and it may, a lot of them will seem common sense perhaps, but I'll bet there's something in there you probably hadn't thought about too. So it's worth a review if you haven't looked them over in a formal way.
Oh, I was muted. Thank you, Dr. Caudill. We just want to say a big thank you to each of you, and please feel free to unmute and jump in if you do have something else you want to share before we end our time here today. But just a thank you to everyone joining us. We really appreciate you taking the time out of your day to join and learn. I will remind you all that this is recorded and it'll be sent out within the week along with those follow-up materials. So please keep an eye out for that. And you can always email me or MHA and our webinars account with any questions. But we just appreciate you, and a huge thank you to our panelists for being here and sharing your thoughts, perspective, and knowledge on this important and growing topic. So thank you all and have a wonderful rest of your day.
Thank you.
Thanks,
Bye,
everyone.
everyone.
Thank you.